We're just getting a little set up still, but I'd like to thank you for attending this webinar today with Fullscript and Lifestyle Matrix Resource Center. The LMRC is a clinical program and education branch of Ortho Molecular Products. My name is Kaylee, I'm with Fullscript, and we are very excited to have Dr. Shilpa Saxena here today to help us navigate diet, statins, and supplementation of cardiometabolic disease. A little housekeeping first before we dive into everything, that I just wanted to remind everyone that this is being recorded and will be sent to all registrants a link to the recording in their email after the event. But you can also find all of our webinars on fullscript.com/webinars, so it will also live there. Throughout the webinar too, if you have any questions, there's a question section on your dashboard. You can add any questions there. I will be monitoring them on the back end, but we'll also have a live Q&A at the end that I will pop back in to help with. So yeah, again, I'd like to thank Dr. Saxena for being here today. I'll let you know a little more about her. If you don't know, she is a board certified family practice physician who is passionate about sharing her innovative patient education and practice management solutions through her classic Keep It Simple style. She serves as faculty with the Institute for Functional Medicine and the Arizona Center for Integrative Medicine. She also serves as a clinical expert for the CMS Vitals program at Lifestyle Matrix Resource Center. She's an expert in the group visit medical model, a creator of group visit toolkits, and the co-author of The Ingredients Matter India. So with that little bit being said, I'll see if we're ready with Dr. Saxena here and pass it over to her, and I will disappear for a bit and then jump back in when we have a little Q&A.
Hi, everyone. It's nice to have you. Kaylee, can you hear me okay?
Yep, I can hear you. I think I'll monitor the questions, making sure it looks like everyone can hear you now, but I'll pop back in if there's any issues, but sounds good.
Okay, perfect. Thank you.
Okay.
So thank you, everyone, for joining us in this lunchtime webinar. Obviously, you may be listening to it later, but I appreciate the time that it takes for you to learn new things, and it's my privilege to share this time with you. This is a topic that many people are always asking about, whether they're new to functional medicine, integrative medicine, or have been established. Like, how do you really keep up with these things that are going on, and medical legally, clinically, operationally? So let's get to it. So we're really going to navigate some of the big points: the when, the what, the why, the who even of diet, statins, and supplementation in cardiometabolic disease. And I'm coming from a primary care perspective, not from a cardiology perspective. However, I would suggest, if you are a cardiologist or endocrinologist or specialist, please know that, of course, most of your patients have these risks of cardiometabolic disease. So it behooves all of us to incorporate this, to make sure we're all doing these base kind of recommendations. So what am I talking about? Well, we want to understand how to leverage lifestyle specific nutraceuticals and specific pharmaceuticals in order to help our patients with cardiometabolic risk factors. And what we want to do is dive into, what is lifestyle? What do I mean by that? What nutraceuticals, what prescriptions, when would certain things get layered in? Why would they get layered in? And for whom should you use which therapy? And that's kind of the whole personalization that we're looking for, right? And just to use that word personalized, there's so much to personalization that we can really help our patients not follow a recipe. There's this wonderful kind of expression in functional medicine, which is, we don't treat the disease, we treat the person. So not every person with cardiometabolic risks have the same risks. So we must personalize therapy. We want to integrate lifestyle nutraceuticals and pharmaceuticals as necessary into their life. We're not just looking at them as a body, but as a body within an ecosystem, socially, mentally, emotionally, financially. All these things matter. Next, we want to be real savvy about medical legal aspects, because we are leading edge, we are pioneering when we offer these types of options, but we want to be consistent with the standard of care as well. And last but certainly not least, we want to make sure that you have access to understanding how to safely deprescribe, since that is a sexy concept that functional and integrative medicine docs get access to. That's not to say it doesn't happen in conventional medicine, but it's surely a bigger focus in our work. So let's start with just a big understanding of why I'm using the word cardiometabolic versus cardiovascular. See, when I use the word cardiovascular, that kind of brings up images of typical conventional risk factors, the most popular one being LDL cholesterol. So the difference that we will expand upon is even within cardiovascular medicine, we can expand from understanding cholesterol versus lipoproteins. We can understand the nuance between calculated LDL cholesterol versus measured LDL cholesterol. As many of you may have learned or remember, there is this Friedewald equation by which most lab companies will calculate the LDL cholesterol. However, if the triglycerides are increasing, it becomes inaccurate. So you'll actually see if the triglycerides usually register above 400 that you will get a, trigs too high to calculate. So you're actually getting a calculated number, which is a surrogate number. It's not an actual measured number. And because high triglycerides and many times low HDL are very associated with insulin resistance, the calculated LDL is an inaccurate risk predictor in these patients with metabolic issues. The other thing to note is historically, when we talk about cardiovascular disease risk, we actually operate or used to operate more like luminologists. Now I'm making up that word, lumen meaning the arterial lumen. And we really were studying, the patency of the lumen, right? We were looking at flow dynamics, like what percent blockage does this person have? What's the valves? And, how is this affecting flow? And historically, we had a belief, and many people still do, that the arterial wall environment is mostly fixed, meaning like you're this percent stenotic and, the goal is to stop the stenosis, but not really are there people who are thinking actively within the conventional standard of care, how do we reverse stenosis, or how do we reverse and improve the flow dynamics? Cardiometabolic now incorporates cardiovascular, but it starts to enhance. It starts to look even globally past just the vascular component. So we're looking at LDL particle number because this number more accurately affects or accounts for the effects of insulin resistance. And with so many people who are either undiagnosed or diagnosed metabolic syndrome, we know that this factor, if unaccounted for, leaves many people vulnerable to cardiovascular events. LDL particle also is a measured number, and we can substratify it as small, dense LDL, which tells us even more accurately what their risks may be. And if that small, dense LDL then further becomes modified, usually as an oxidized LDL particle, that's even one step further along the process for plaque generation, plaque development. So we can look at LDL particle, how much of it is, so we want to look at a total of LDL particle, then how much of it is small, how much of it has become burnt, if you will, through inflammation to be an oxidized form, so that we know what is there that the macrophages can put down as plaque. Metabolic dyslipidemia is something that's equally happening in the lumen and the arterial wall. So you can have these triglyceride-rich LDL particles, or if you're just doing a standard lipid panel, you can look at the triglycerides over HDL, and if it's greater than 3, that should signal you to think there's a metabolic component to this person's issues. And why is that important? Again, because it's hidden risk that you can leverage. You can reduce, reverse, and therefore affect the end outcome of a cardiovascular event. When we start bringing in both cardiovascular and cardiometabolic, and we call that a global risk assessment. And we look even beyond just the lumen, and we're looking at the arterial wall, we're looking at the endothelium. Is it quote unquote leaky? Is it inflamed? Is it oxidized? Is it working in terms of its function, responding to nitric oxide? And what's the plaque what's going on with the plaque? Is it rupture prone or is it calcified? Then we're really looking at this expanded ecosystem of cardiometabolic medicine. And what we know is when we find and we look for rupture prone plaque, we can actually modify that by leveraging antioxidants, anti-inflammatories, lifestyle, certain herbs and botanicals that we're going to talk about. So one simple view of cardiometabolic medicine could be look for drivers of insulin dysfunction and inflammation, because that mixed with a person's unique genetic code will lead to various comorbidities. Now, you might find them, if you will, at the level of comorbidities, meaning you would find them with PCOS or fatty liver or diabetes or hypertension. Those are all downstream phenomenon, which are a byproduct of insulin inflammation meeting with their unique genetic code. But if you see those diagnoses, you should be thinking backwards, upstream, if you will. Okay, if they have these things that are cardiometabolic risk factors or conditions, what's going on with the insulin and inflammation level for this person? Obviously, you can't change the genetic code. The goal is to epigenetically change the influences on the genetic code. You can do that microscopically and you can do that telescopically. So microscopically, you can work on cellular inflammation, cellular energy, oxidative stress. You can look at the gut microbiome, right? And these are looking at things on a microscopic level. Of course, you can look at things on a telescopic level, looking at social determinants of health. But all of these help you understand where you can look when you have people with cardiometabolic conditions or risks. You want to look deep in the body, and then you want to look outside the body for leverage points. And just to kind of make it clear, what do I mean by cardiometabolic conditions? So yes, you have people who have cardiovascular risk factors, whether it's elevated, you can call it hyperlipidemia, or if they have known heart disease, stroke, peripheral artery disease, so on and so forth. You know, kind of the typical vasculopaths. What I want you to consider is that there's also people who have cardiometabolic risks that may not be caught if all you're looking for are vasculopaths. So people who have altered body composition, not just the traditional overweight or obesity designation by BMI, but they might actually be skinny fat, i.e. sarcopenic, but still viscerally obese or overweight, meaning that they have visceral fat, but because they've lost muscle, they net look normal on a scale or in range, if you will. So altered body composition is a huge risk assessment tool to find people early. You can also find people at pre-diabetes versus waiting for them to be diabetic. You can diagnose someone with metabolic syndrome. Very commonly, these people are already down the path of dysfunction. Fatty liver patients, non-alcoholic fatty liver disease, they again are a downstream effect of insulin plus inflammation on someone who's uniquely predisposed genetically and environmentally to liver dysfunction. PCOS, same phenomenon, insulin inflammation affecting this person's unique genetic predisposition for ovarian downstream issues. Then type 3 dementia. This is insulin resistance in the brain, otherwise known as Alzheimer's. You can look for people who have, if you will, genetically predisposed brains to insulin and inflammation. Osteoporosis, we're talking bones. Estrogen-driven cancers like breast cancer, we're just talking somebody who's genetically predisposed to insulin and inflammation, and it's manifesting in breast and cancer. It can also be with prostate cancer or colon cancer. Those are all estrogen-driven cancers, which again are driven also by insulin and inflammation. So what I hope you see first off the bat is that lipid management is not just about looking at the lipids. So this is kind of the way that you can start to look at your patients. When you see someone who has elevated lipids, if you can get the specificity of knowing if it's small and dense or if it's oxidized, that's even better. If they also have elevating glucose, right, or if you're able to check an insulin level, now you know, okay, I'm dealing with a cardiometabolic patient. So if you see someone with those risk factors, and notice I say elevating, I don't say like a blood sugar of 126 or even 101. For me, if it starts going up above 85, every point that it's going up above 85 as a fasting blood glucose, I'm starting to look at other things that are going up. Are the triglycerides going up? Is the hsCRP going up? Is the LDL particle number going up? Is small dense LDL going up? All these things will tell me I need to go look deeper. So where do I go look? I go looking for insulin dysfunction. And what can cause insulin dysfunction? Well, if you look at the circle beyond it, well, I start looking for causes of, I look for inflammation and oxidative stress. I always call inflammation the fire and oxidative stress the smoke, the secondary smoke of the fire. Both are harmful. Then I say, okay, if they have inflammation and oxidative stress, inflammation, I might test through hsCRP. I might look at platelets as an acute phase reactant. I might look at the white blood cell count to see if it's in the top quartile, if that's starting to make me suspicious for maybe some sort of chronic co-infection or subacute infection. I look at GGT as a measure of oxidative stress. These are ways that I start saying, this might be going on. Then I say, what's causing the inflammation and oxidative stress? Okay, well, that's when we're getting into the lifestyle bit. What's their physical activity? What's their weight? What's their microbiome, nutrition, stress levels? Do they have trauma? Is there a subacute infection going on? So you see, I'm always looking for the cause, going upstream, upstream, upstream. Of course, I'm doing that because if I can turn it off upstream, then these elevated glucose and lipid numbers get improved downstream just by default. The other place I look for insulin dysfunction is the mitochondria. Environmental toxins can bother mitochondria to the point where they do not either output insulin or they can make the peripheral tissues like skeletal muscle and adipocytes resistant to the insulin signal. So I'm looking at their just lifetime accumulation of toxic burden as well as signs or symptoms of mitochondrial dysfunction. So this is how I approach a patient who is a cardiometabolic in terms of their goals or in terms of maybe my goal for reducing their risk. Now, so who do I look for this for? Well, I'm just going to go ahead and say modern day Americans, or I'll just go ahead and say modern day Western civilized humans. And notice I included kids. Kids are just, adults waiting to happen, hopefully. They're adults. Adults are just further along the continuum of risk. So my goal is to catch risk early so that I can stop the downstream effects. I can get the insulin and inflammation addressed earlier in life. Notice whether you have a family history, and even if you don't have a family history, these are lifestyle diseases primarily. Yes, there is a small fraction of people who have genetic familial hyperlipidemia or hypercholesterolemia, but the vast majority, patients have lifestyle or environmental diseases. See, lifestyles have been what are changing over time. Our genes have stayed consistent for thousands of years. So in order to explain the epidemics of cardiovascular and cardiometabolic and diabetes and obesity, we must look at the lifestyle. Don't think it's family history. If you have an elevated BMI, and if you don't have an elevated BMI, yes, if someone is obese or overweight by BMI, you definitely want to manage that source of inflammation. But if they're not obese, overweight by BMI, and they have other either history, physical exam, or lab markers that make you suspicious for cardiometabolic risk, make sure you rule them out for being skinny fat or sarcopenic. You can do that by looking at a waist circumference and a waist to hip ratio. Now, what do we do with lipid management? Well, there's three main stages that you can look at. There's real prevention, meaning They have no calculated risk, whether you use Reynolds risk score or Framingham. When you put it in, they really don't have a calculated risk. So there's no current risk, and that's when true prevention can occur. Most people you might be seeing have some risk factors that exist. So our goal with them is primary prevention, prevention of the first event. Of course, there are people where they've already had an event like a heart attack or a stroke, and therefore the goal would be preventing the next event, right? Their risk factors are proven real. Now, for the sake of this discussion, we know that the rules are different based on which prevention strategy you're aiming for, but in general, my lecture is based or focused on people who might fall into this primary prevention category, and of course the real prevention, but let's just say primary prevention. So then the next goal is, well, when do you do what, right? When do you do lifestyle? When do you do nutraceutical? When do you do pharmaceutical? Well, here's my answer to lifestyle. It's pretty easy, all the time. You always want to bring in lifestyle medicine, using it to lower inflammation and oxidative stress. So you want to leverage what would be nutrition, the cardiometabolic Mediterranean diet-based food plan, exercise, stress, sleep optimization. And the goal here when you're leveraging lifestyle medicine is to tailor what you do, meaning whether you choose to work on nutrition, exercise, stress, or sleep, based on the patient's readiness, right? What you do and when you do it is based on the patient's readiness. So what do I mean? If a patient is all geared up, like I am so happy, I'm so excited to start doing a couch to 5K program, and you come in with a cardiometabolic food plan and that's not where they're excited, this is not where I start. I was like, oh, you want to start with the best anti-inflammatory signal called exercise? Let's do it. And then when they're rocking the exercise or even at least getting successful at it, I would do a follow-up and then say, hey, now what? Do you want to work on nutrition, stress, sleep? Like that. You tailor what you do and when you do it based on a patient's readiness and sense of self-efficacy, meaning their sense of ability to do it and do it well. Lifestyle therapy for me also includes lowering the environmental toxic burden. So just slowly but surely chipping away at these kind of common lifestyle factors that increase cardiometabolic risk. So excess alcohol, sugary drinks, processed foods, things in our environment that we just put on our skin, put on our mouth, spray in our hair, things that we do as hobbies or occupations that just add to environmental toxic burden, could damage our mitochondria, so on and so forth. So remember, lifestyle therapy all the time, and the focus is to lower inflammation, oxidative stress, and toxic burden. Now, what can you layer on top? Well, how about nutraceutical therapy? Most of the time, I notice that my patients need some foundational support. I always start with vitamin K2, D3. I look for magnesium deficiency. It's real easy to find. Many of my patients are also deficient in essential fatty acids. I do that by checking an omega index. And many of them don't have guts that are so happy. So I might create some immune tolerance with some probiotics, just some gut happiness to reduce inflammation at the level of the microbiome. But then I might be more targeted in the cardiometabolic world. If I see that I want to improve LDL quantity and quality, I might add bergamot. If I see that there's things going on at the level of the microbiome that's creating inflammation and or there's blood insulin issues, I might add some berberine. If I feel like insulin sensitivity can be enhanced, I might use alpha lipoic acid, vanadium, chromium, or blends that have these things put together. If I see that there's a metabolic dyslipidemia in play, I might use niacin, assuming the liver is healthy enough to handle it. For some people, there's mixed opinions about red yeast rice and the sourcing of it. Can it be pure enough, or are you really just getting a statin in disguise? But if you are a fan of red yeast rice, just monitor for statin-like risks, because it will deplete CoQ10, for example, since it does hit that HMG-CoA reductase button. So we're learning that lifestyle therapy is all the time. Nutraceutical therapy is most of the time on foundational support, and most of the time you need to add in one or more of the targeted support nutrients I listed. Now, pharmaceutical therapy for me is some of the time. So statins are generally recommended for secondary prevention for sure, or if they're a high risk primary prevention person who's still in the high risk calculation. Now, what you'll find is that you're going to have people who come to see you who say that they have had a negative experience with statins, i.e. they're intolerant. So assuming that that's documented and that they refuse or defer on taking statins at this point, then you really want to leverage lifestyle and nutraceutical therapies, maybe specifically Bergamot to start with, right? But of course, consider all the other ones because you need to create the context of reducing insulin and inflammation to healthy levels. You might then also have people who are not even intolerant, they just flat out refuse. For these people, again, you want to consider the lifestyle therapy all the time and targeted nutraceuticals with documentation. So let's talk about that a little bit, okay? We're going to get to that here in a section. Personalized, how are we going to personalize this stuff? Well, I want to make sure that you get that there's this wonderful thing called Prochaska's trans-theoretical model of change. And what it says is that you've got to figure out where people are at about any therapy or recommendation that you have for them. So for instance, I'm just going to use the example of, let's say, going gluten-free. If that's something that you believe this person can do to reduce insulin and inflammation, then it could be that this person doesn't even know what gluten is. So they're a pre-contemplator. They didn't even know to think about it. So what you might do is get them to contemplation, like, okay, well, here's some handouts about being gluten-free and its association. And they might say, oh, forget it, I'm ready to go. So then you might say, okay, here are some cookbooks, or meet with the health coach so that she can prepare you for how to be gluten-free. And then the health coach's job is to take them from preparation into actual action. Like, this is my go gluten-free first day. And then that person would be in action. And when they hit around 3 months, they would be in maintenance. Now, many of us know that whether it's, exercising, not eating gluten, stopping smoking, you could be in maintenance for 6 months, 10 years. And all of a sudden, something happens and you go back to your old ways, almost like you forget that those were issues. Well, then you're back in pre-contemplation. So you got to go through that model of change again with the patient. Now, there are some times where someone is in maintenance for so long. My classic example is brushing your teeth. Like, there's very few adults that I know that give up on brushing their teeth. They're out of this cycle of change or model of change. They've terminated out of the cycle because they're never going back to not brushing their teeth. For most people, they're in the cycle for those cardiometabolic risk factor reduction therapies, right? Like, they're pre-contemplating vitamin D, then they're in it, and then all of a sudden they go to an Indian wedding like I do, and the poop hits the fan, I forget about all my good behaviors, and it takes me a little while to get back into rhythm. Now, what I want to also say is this is a lot that I've just told you. Lifestyle medicine isn't like eat right and exercise. There's so much more to it. So what we've found, and research proves over and over, is that humans are social beings. And if you wanted to leverage time with your patients and leverage your team members, meaning like your health coach or even your set of skills around lifestyle medicine, you can bring people together and conduct a group medical appointment. We have tools to be able to help you. You can go to groupvisittoolkit.com for a whole slew of cardiometabolic and functional and integrative topics that have been pre-made as easy kits for you to be able to give 90-minute appointments to 16 people, billing 16 people in 90 minutes. It's wonderful. Everybody gets 90 minutes worth of information, but they only had to pay for your visit once, at a much lower fee usually. So remember, when you're meeting a patient, personalize, figure out where they are in these blobs, if you will, and see what you can do to leverage those points. Now, let's talk integration. If someone does need a prescription statin based on, let's say you do a calculation and they're high risk, but they are, let's say, intolerant or refuse. One of the early things that I might try if I want to be able to help reduce risk in the short term is I might try rosuvastatin twice weekly. It has a longer half-life, so I like that one. And maybe I can get, if you will, a touch of statin effect, but I can use my lifestyle and nutraceuticals to make up the difference. I start with twice weekly. It might end up 3 times weekly. It might be low dose rosuvastatin every single day until we get their risk score better and they are doing better with lifestyle and nutraceuticals. So I always create the context of deprescribing when I start a statin if they're really resistant to it, because most patients assume that once they start a prescription, they'll have to be on it for life. So I do goal set, like, listen, we're putting it on now, but my goal is still to work with you on lifestyle and nutraceuticals to get you off of it, or at least to lower the dose. Now, let's say that a person wants to not take a prescription that's indicated by standard of care. Well, then I would say make sure you risk stratify that person. Is there time for a trial of lifestyle and nutraceuticals alone? And then repeat the studies in 4 to 6 weeks. Because actually, if you look at ATP3 guidelines, there is some mention of lifestyle medicine, therapeutic lifestyle change that can be tried after risk stratification. Obviously, when you're making these recommendations, you've got to integrate in, like, what is this patient's available income, time, and support to be able to do the things that you are recommending? And do they have competencies, nutrition, exercise, stress reduction techniques, sleep hygiene, or do they need some support from somebody on your team or through handouts or through technology, etc.? Giving the recommendation is not the same as making sure that they're empowered to succeed with the recommendation. Medical legal. Well, you've heard this before, document, document, document. I generally would recommend that you maybe create like a standard template of the standard of care was offered. The patient's preference was to not take a statin. Patient understands that untreated hyperlipidemia, diabetes, hypertension can result in XYZ. So you can have that all written every single time you do go against standard of care so that you are covered, at least that the standard of care was offered and risk benefits alternatives were documented and discussed. Now, if somebody isn't, let's say that medical legally you document this, and then you're going to say, well, listen, I'm not just going to do this and tell you to come back in 6 months. I usually ask my patients, if I'm going to go against the standard of care, I want to see them more frequently to show, to document that what we're doing with lifestyle and nutraceuticals is working. So we make sure that they're seeing either myself or a health coach monthly to quarterly, depending on how risky their score was. I repeat labs, again, to track progress or lack of progress, and then we show that we're making a new informed decision each time. I document my new plan each visit. We mentioned that the standard of care was offered, risk benefits alternatives. Again, you can put that, that little templated aspect into the note again, and that's how we do it. Listen, there's also going to be times where you may be uncomfortable not giving a statin, and it's okay to say, I don't feel comfortable not prescribing a statin in this area. But many times you can do a 3-month trial of the lifestyle and nutraceutical therapies with serial measurements showing maybe at 6 weeks and at 12 weeks that the patient has made considerable difference in their risk measurement, and you show the risk calculation, and therefore you've given the patient something that they're really excited about and maybe something that you got excited about. What you may also find is that you may have to deprescribe when you're doing lifestyle therapies, nutraceutical therapies. So when you're doing your serial visits and repeating labs, you can see if it's time to be able to pull off maybe a statin one of the things I always like to do is create this context that, hey, we're so excited to be able to pull these medications off. So be sure to stay with us so that we can find the proof that it's time to do it. And so what I usually will do is either reduce the dose of the statin while adding a nutraceutical to make up the difference if needed, and I recheck, usually between 1 to 3 months, depending on where their risk score is. I'm always documenting their progress, and let's say I do something and it didn't work because life happened. Well, then we say again, okay, is the risk acceptable for us to do lifestyle and nutraceuticals again? And then sometimes I might say, it's not good now. You know, whatever happened this last 3 months, your risk went up. So we stop the lifestyle and nutraceutical alone strategy, and we might add on a statin. And then we might try again at a different point in life when they're in preparation and action mode to really take on lifestyle. So here's the truth. People don't care how much you know until they know how much you care. All these things that I taught you are definitely important in the ways to be able to help patients with cardiometabolic conditions or risks, but they really, really appreciate and love to partner with someone who really cares about this created context of getting healthy and getting well and not needing pharmaceuticals or not needing as much pharmaceuticals. We want to help you because there's definitely a lot of information and patient education, and getting these patients really empowered requires some tools. So the CM Vitals branch of the Lifestyle Matrix Resource Center has created, with my support and so many other people like Tom Williams, these tools that you can use that are just ready-made to be able to teach patients some of the principles that I've taught you. There's a whole process in which we help you onboard your practice into learning how to use the tools. Again, it's the same thing I mentioned with patients. You can give them the tools, but unless you know that they know how to implement them, they're not very useful tools. So wouldn't the same principle apply to you? We know that the science is important, but without teaching you how to implement and integrate the science, then it leaves you hanging there as well. We want you to have self-efficacy. So there's ways that we can help you use marketing, use drip campaigns with emails, use cardiometabolic wellness scores to keep your patients engaged in this conversation of cardiometabolic health. There's ways that we can help you and your practice just work through how to get the most out of the entire program so that you are, using all aspects or many aspects of what's available to you. It's like getting a new EMR or a new watch. It's only as good as the features you can use. Like I said, I mentioned that we have wellness scores and drip education emails available for you just because most practitioners and practices do not have the bandwidth or expertise to create all these things all the time. The group visit toolkits we have available really focus around some of the lifestyle points that I've been mentioning. Advanced prevention for cardiovascular disease focuses in on inflammation, really helping people understand inflammation, whereas protecting your heart, the blood sugar insulin connection starts to bring in that component of insulin. And then of course we have movement as medicine, helping to leverage exercise as medicine in your practice. So I thank you for your attention, and I'm going to come back to you all, and I hope that we've answered all your questions, but it's unlikely because you all are curious. So let's see, Kaylee, what kinds of things we have available that we can help answer questions.
Yeah, can you hear me okay?
I can.
Okay, perfect. Yeah, we got a lot of questions coming through. It's been great. So you'll have to bear with me because some of the pronunciation might be a little off, but let me try and see. Okay, so kind of going back to the beginning of the presentation, there was a slide under your elevated glucose and lipids, insulin dysfunction under the Y. A question came through. The trig/HDL ratio, is this applicable to Canadian lab values as well?
I'd have to know what the Canadian lab values are, actually. So I don't want to say yes. So I'd have to know what those are.
Yeah.
So I apologize. I don't have that answer and I won't act like I do. So how about we try to figure that out? Um, yeah,
Yeah,
maybe
I
there's
can
a conversion tool. I would think there's
that
probably a conversion tool that you can use to put, you know, a Canadian or European metric lab into American units and then see if the ratio is 3. But, you know, the thing is that as the trigs go up and the HDL is going down, as that gap starts to increase and widen, the bigger that gap, the more insulin dysfunction that's likely going on. That's kind of the principle underlying it. So 3 is the number we say that it's starting. But if somebody has like an 8 multiplier between trigs and HDL, then it's almost pathognomonic for insulin resistance. So perhaps, at least for the interim, just look as the numbers are spreading apart from each other, that's likely more and more risk for insulin dysfunction.
Yeah, that's interesting too, to see that difference between, you know, the countries, or understand that difference for me anyways.
Yeah.
A couple others at the beginning kind of the presentation. I guess you might have also maybe covered it as you went, but how do you identify if a person is statin intolerant? Statin?
Yeah, so statin intolerant, usually the patient is the person who tells you, I was placed on a statin by my previous doctor, I had muscle cramps or my liver enzymes went up. They're usually the ones who will tell you, and if they don't know and you put them on a statin and then they tell you the typical side effects, then that might be someone who has statin intolerance. You know, I think that the documentation piece is most important. There may be people who don't have, you know, statin intolerance by definition, but they are not going to take it because who cares what the definition says? If they had a terrible experience, they are intolerant in their eyes. And so you just have to document that and then say, okay, well, listen, this is the standard of care, but I'm willing to work with you on lifestyle and nutraceutical therapy. Let's just keep a close eye and then we'll see if this makes up the difference. And if it doesn't, and you still need a statin, let's see if there's another way to do the statin. Like maybe they were just on too high of a dose all at once. Maybe they could be on a lower dose, or maybe they could be on a different one, like the one that I talked about, rosuvastatin twice weekly, that could help.
Okay. So someone came through and said, I know that a too low LDL is harmful as well. What is your low end? If it's too low, how do you handle this?
Very good. So LDL is, I always call it the lousy LDL, and I say terrible triglycerides and healthy HDL. But the truth is that LDL is not lousy all by itself. It's only lousy when it's too high. So LDL, and again, I apologize for knowing my metrics here in the US. So 70 is the goal for people for secondary prevention. It would be like the A+ goal for someone with primary prevention that has high risk factors. But if you start going below 70, especially if you start hitting 40, you don't have enough LDL for good brain function or hormone production. And the causes for that generally are two things. Either the statin has been, you're over treating with a statin or some pharmaceutical. And the other reason is that they're not either eating enough dietary good fat or they're not absorbing their fat. So they might have a malabsorption issue. So if they say they're eating good fat, like they're eating avocados and coconut and nuts and seeds and clean, you know, salmon, but their LDL doesn't look above 70 or around 70, then it could be they're not absorbing the good fat. And so you want to look at their gut and see if you can make that healthy so they digest and absorb the good fat.
Okay, there are so many questions coming through. This is great. One of the questions too, it's a longer one, but they said they have a client who has lowered her risk factor significantly. However, her arterial calcification score in 2020 is up from 2017, getting her on the risk category. Do you recommend reevaluation of nutraceuticals or any other suggestions they might be missing?
So what I'm understanding is that, like, it seems like all the risk factors are moving in the right direction, but the calcification of the plaque is moving in the wrong direction. So that means there's something missing. So when you look at my Y slide, see if there's something going on with the mitochondria or toxins that could be causing risk. Now, sometimes toxins can cause risk that is independent of inflammation going up, insulin going up, or lipids going up. Toxins can cause issues directly. Autoimmunity is another place that you can look, because autoimmune damage to the vasculature could be what's driving it. Make sure that they don't have anything like that. And of course, there's always stress. Sometimes people who are so perfect at lifestyle are actually a little too intense. So make sure you bring the mind-body component in. Now, of course, there's research that would say that, and this is a diet that many people may have difficulty with, but Dr. Caldwell, he has like a no-fat vegan diet that has been shown to reverse plaque that could be considered. The other kind of supplement that comes to my mind is when people give vitamin D3 without giving K2, remember that that is something, excuse me, that is, oops, do y'all still see me?
Yep. Oh, actually.
Oh, do you see my screen?
For a second. Yeah, we can see your screen.
Okay. Oh, sorry, I gotta go back to this. Let's see if I can find myself.
There you go.
Apparently, I am not. Okay, let me keep answering the question though. Learn how to find you, Kaylee. Okay, as long as you can hear my voice, I guess, right?
I can see you now too. So we can see your screen and you, I believe. That's what I can see at least.
Okay, I'm gonna shut this down. How about we do this? Okay, so vitamin D3 by itself does signal calcium to get out of the blood lumen, if you will, but it doesn't tell the calcium where to go. So you need vitamin K2 to say, go to the bone. Otherwise, without K2, the calcium might go into the arterial plaque and calcified plaque. So D3K2 is what you should consider if perhaps the calcification is going in the wrong direction. So consider all those things as a start.
Okay, that's great. A couple questions that came through about bergamot. So what dose do you use most often with bergamot, and how long until you see results? Does bergamot help with LPA? I might be saying that wrong.
Okay, so
yeah.
Bergamot, the dosing, it generally is available as a 500 milligram capsule. And you would take 2 at bedtime. Remember that your liver has a chronobiology where it's most active at night. So taking your lipid-focused medications or liver-focused medications / nutraceuticals near bedtime is best. So bergamot, 2 capsules at bedtime. Not all bergamots are created equal. The ones that, of course, I prefer to use are the ones that have been shown in trial to actually affect LDL. I have not seen that bergamot helps Lp(a). I generally try to reduce inflammation, but I have seen studies show that that bergamot will reduce LDL cholesterol. And I've seen in my clinical experience, it also reduces LDL particle number and small dense LDL, as well as oxidized LDL, and it reduces inflammation and improves insulin parameters. That's why it's so nice. Now, bergamot, I kind of lean more towards the LDL portion, whereas berberine is more towards the insulin portion. So together, they're really nice too.
I think we had a question on berberine too, so that helps answer that, I think, as well. A question came through too. If your patient only wants to try nutraceuticals, what is the time frame for retesting to see if they are effective?
So what I would do is calculate a risk score, whether it's Reynolds or Framingham, and then just make sure that they qualify to do a nutraceutical and lifestyle therapy alone. Remember, don't do nutraceutical alone. You have to make this emphasis on lifestyle. You can't just like, I'm just going to eat fast food all the time and take supplements. You can't do that. You don't want to teach people that they're just substituting a pharmaceutical for a nutraceutical. So what I generally do is getting a sense of the risk score. I would decide if I should see them again. Generally in 6 weeks is what I do. So I give them a chance to do 4 solid weeks of lifestyle and nutraceutical therapy. And then I repeat the labs, and then I meet with them. And then if I see a significant drop, I say, let's do this again. And then I would do it again in 6 weeks. And then if it looks real good, then I'd say, let's repeat in 3 months. So, but again, it depends on how the drops are going and what their
Yeah.
initial risk score was. Yeah.
So I guess kind of along the line of like higher and lower risk, what are the doses that you would use for foundation supplements? Are there any you would change for someone with higher or lower risk?
So your vitamin D3, K2, you dose according to their vitamin D25 hydroxy level. My goal of that is to get them to between 50 to 80. Again, I apologize. I know my American units. I don't know my Canadian and European units. So 50 to 80. So in our range is 30 to 100. So I pick 50 to 80, if not 60 to 80. That's my goal. So I treat to that goal for D3, D3K2. For magnesium, I like to aim for the top half of the reference range. Okay, so for us, it's 1.5 to 2.5. So I aim to have it above 2. But then I also look at clinically, like, hey, are you prone to muscle cramps? How are your bowel movements? How is your, blood pressure? If I'm noticing blood pressure looks good, these things look good, and their magnesium is in the top half, then I feel good. And I would make sure when you dose magnesium, you don't dose too quick, too hard if they have kidney issues. Probiotics, that, you can't, probiotics, you want to find the probiotics that you like, that work for you. I just use that as a maintenance. Generally, I don't go to 30 billion for most people. You could probably have a maintenance for most people in the low billions. But if they have gut dysfunction, consider going into 10, 20, 30 billion for 1 to 3 months. And then essential fatty acids, most people I like to have on 1 to 2,000 milligrams of EPA DHA per day. Make sure it's pure and potent, and make sure it's taken with food. Same thing with D3K2. These are fat soluble vitamins or nutrients that are better when lipase comes out to pull it into the system.
Okay, we're getting closer to the end of the time, and I know a lot have come through, but there are a couple questions about some resources or references. I know a bunch have come in for your group visit toolkit website, so I was thinking that's something we can share, in the follow-up email or on our landing page, just so they have a quick link to that. So we can definitely.
An implementation team. Real quick, Kaylee, like if you let us know you're interested, again, we get that having the kit doesn't make it happen in your office. So we have an implementation team that will help them meet with their practice if they purchase the kit, so that then they can show them how to make it work in their practice.
Oh, wow, that's great. Yeah, that's a good resource and a good point to include as well. I know one question came in. Do you have a resource or a reference that will help a new IFN dietitian to understand the difference between cardiometabolic labs or their ranges, or I guess maybe any resources for new IFN dietitians or practitioners?
I don't have a resource, but what I would, not like a handout, but that's where the CM Vitals program comes in. Because what we have is a whole implementation guide, an in-practice guide. We have patient scenarios. We show which labs we order, which supplements we use when. So it kind of is a little like boot camp in cardiometabolic medicine. So I think that resource, there's little pieces you can buy, or you can get the whole kit with the onboarding, and it will basically give you a turnkey way to bring in cardiometabolic medicine into your practice from beginning to end, including the group visit in there.
Oh, okay. Yeah, that would be a great resource. Okay, we have so much great feedback for this, and a ton of questions coming in. I think we can include some of those resources or links to those resources in our follow-up. And as I said, this webinar will be easily found on the Fullscript website, fullscript.com/webinars. We'll be able to host it there, but you'll get a link to that in a follow-up email. I'd like to thank you, Dr. Saxena, for being here today. Great presentation. I know I learned a lot, even if I can't pronounce some of the things properly.
Awesome.
But yeah, if there are any more questions, we can email Fullscript webinars@fullscript.com. I can try to pass some on, or we can hopefully answer them with the follow-up in this recording.
And real quick, I believe that Fullscript has influencer protocols. Is that right? And if you would like, I'm happy to create some that are centered around this lecture so that people have a sense of some ideas of what, combinations work well together.
Yeah, we have protocols, like a library of protocols that you're welcome to, we can talk about creating one and sharing them with, we are now able to share protocols with a practitioner's whole patient list or specific patients. So it's a great resource we have as well, and I'm sure we'd love to have you on there. So that is definitely another resource we can include.
Yeah, wonderful.
All right, well, thank you again so much. This was great, and I hope that everyone enjoys the rest of their day.